Why are you not cooperating today? I do tricks, not you. All right. We got Kayla behind the camera today, and we got me in front of the board. It's time to get started. We're going to talk about kidney. So she was not very specific on the test plan. She said to go over glomerulonephritis, nephrosis, kidney trauma, a bunch of stuff that's on the back of the board. Dialysis is going to be the main thing, but overall it's 11 questions. So I'm going to try to go through all of it and catch my breath in the process. So first things first, we got glomerulonephritis. Now you see we have neph and ritis. So kidney inflammation. That's what it means. And what we have is inflammation and scarring of the kidney. Now what we're going to see with glomerulonephritis is a decreased protein in the urine. Now it is caused by infection, which is usually strep. So if you see they've had a recent strep infection, then you will assume that they've had glomerulonephritis over anything else. Now the signs and symptoms, according to simple nursing, is going to be decreased protein in the urine, recent strep infection, fever, WBCs that are elevated over 1,100, creatinine over 1.3, BUN over 20, urine output under 30, and all this is indicating inadequate kidney function. This WBC indicates the infection. We're going to have an increased blood pressure, edema, JVD, fluid in the lungs, all related to fluid volume overload that you get from glomerulonephritis. Now, Ms. Solomon, what she put in the PowerPoint is an abrupt onset of hemat or proteinuria, azotemia 10 to 14 days after, brown or cola-colored urine, hypertension, edema, and you see this in the hands and upper extremities. We also see periorbital edema specifically with glomerulonephritis and hyperlipidemia. So now let's go into the treatments for glomerulonephritis. According to simple nursing, antibiotics. That's what we give them. It makes sense because it's an infection. We need to educate the patients to finish all of the antibiotics. We'll give them antihypertensives. So ACEs that end in pril and ARBs that end in sartan. Got me? We're going to underline this too. We're going to give them diuretics, the ides, like furosemide, and thiazide, like hydrochlorothiazide, because they are in fluid volume overload with glomerulonephritis. And another thing we need to watch for when we are giving these diuretics for glomerulonephritis is hypokalemia. So under, what is it, Kayla? Under 3?
3.5.
I'm just going to say under 3. If it's under 3, you need to call the HCP. 3.5 according to Kayla.
3, call it HCP.
Now let's see, same for albumin. We're going to do a 24-hour urine collection, and we're looking for protein according to the PowerPoint. Now diet, we're going to have a decrease in protein, a decrease in fluid, and a decrease in sodium. In the PowerPoint, it said we're going to decrease this fat, and we're also going to decrease this cholesterol.
Yes.
Now, you make a sound?
I said yes.
Yes.
Sorry.
Yes. Now, keep on make your own audit. Like, you can narrate this.
Narrate?
You can narrate this whole experience. Now, we got hypertension or hypertensive crisis. Now, we need to report these signs to the HCP. Headache, decrease in level of consciousness, oliguria, which means they're not peeing. How many milliliters an hour is normal, Kayla?
30.
30 milliliters an hour is normal. New, sudden, or rapid weight gain that comes from oliguria. Now, next, let's go into nephrosis, which wasn't even in the PowerPoint. We're going over it anyways. It's also called nephrotic syndrome. We're going to have increased protein in the urine. It can be caused by an autoimmune disease, and autoimmune diseases are triggered by the 4 S's, which is stress, sickness, smoking, or sun, also high temperatures. Now, signs and symptoms of nephrosis or nephrotic syndrome. We got increase in protein, decrease in albumin. So as you see, it's different. With nephrosis, Kayla told me this last time, it's like Nerf balls of pee coming out the urethra. So, yeah. Good job, Kayla.
I did
you
that?
Got edema. You
I
did say that the day of the test.
Yeah, I did do that.
Increased risk for clots. We're going to have hyperlipidemia, creatinine over 1.3, BUN over 20, and urine output under 30, which all indicates kidney damage. Also, for treatment, we're going to give steroids that end in zone, like prednisone. And with these steroids, we have an increased risk for sepsis, and we also got to watch for them high sugars. Antihypertensives such as ACEs, they end in prils, and ARBs like sartans, the same things we're giving for the fluid volume overload for glomerulonephritis, we're giving for nephritis. So the antihypertensives like ACEs, prils, ARBs, sartans, diuretics that end in ides or thiazides, and we need to watch for hypokalemia. Under 3.5, we report it to the physician. Now diet, this one is different than glomerulonephritis because this is the only kidney disorder where we increase the protein in the diet. The rest is pretty much the same. We decrease the fluid and we decrease the sodium. Same thing with this hypertensive crisis. The signs we need to report at the HCP are headaches, decreased level of consciousness, oliguria, new, sudden, or rapid weight gain. Now, one of the things she said that was going to be on the exam that I had trouble finding information on was kidney trauma. And so we're going to go with what little was in the PowerPoint because Simple Nursing said nothing about it and Saunders said nothing about it also. Signs and symptoms are hematuria, abdominal or flank pain, swelling, ecchymosis in the flank region. Turner's sign may be present. Now, where's Turner's sign, Caleb?
Turner's on your back.
It's on your back.
Your
Where's
flanks.
colons?
Colon's on your abdomen,
Belly
stomach,
button.
belly button.
Yep. Now we can also have shock with this. We need to monitor for the signs and symptoms of shocks, which is hypotension, tachycardia, tachypnea, decreased level of consciousness, and cool pale skin. Now the treatment for a kidney trauma is controlling the hemorrhage and preventing shock. If it's minor, we just give them bed rest and take the vitals. If it's major, we got to do a nephrectomy. Now, for treatment of kidney trauma, we need to make sure we have 2 IVs, that we're monitoring intake and output, and that we're doing a pain assessment. We need to monitor for bleeding and signs and symptoms of shock and hypertension. And that's all I could really find on kidney trauma. How does this spin?
I think I just figured out how to make this look good.
You did?
Because my zooming was very poor in this first part. Sorry.
That's fine, as long as I get it so I can listen to it tonight, and whoever else wants to listen to it.
My zooming is very bad in the beginning.
Now we're getting into the bread, meat, cheese, the stuff that we really want to know about.
The kidney.
And we're breaking the whiteboard.
Tighten up, Tyler.
Okie dokie.
Tighten up like them pants.
Kidney. We got 11 questions.
Okay.
Should have done that.
Can't breathe.
Okay, so acute kidney injury. That is a sudden decrease in kidney function. We're going to have a few stages. We're going to have 3 stages. Not 3 stages. I didn't screw myself up. There's 4 phases, and there's 3 different types of an acute kidney injury. We have prerenal, and that's decreased blood flow to the kidney. It can be caused by an obstruction or vessel occlusion, according to the Saunders book. We're going to have a low BP, and we're going to have signs and symptoms of shock, like hypovolemia and dehydration. Is your phone ringing?
It's fine.
You can answer it.
It's fine.
We're going to have decreased cardiac output. It can be caused by decreased cardiac output, heart failure, or cardiogenic shock. And according to the PowerPoint, we're going to have decreased glomerular filtration rate and severe dehydration. We need to give fluids, and this is all for pre-renal acute kidney injury. Kidney, we got intrarenal acute kidney injury. No, thank you. You're helping me. Appreciate it. Acute kidney injury, intrarenal. Now, this could be an autoimmune disease that causes this. It could be NSAIDs, mycin, antibiotics, CT, or contrast. All these things can cause intrarenal acute kidney injury. Now we have postrenal. That can be from a renal blockage, like a calculi or a tumor. We're going to do stents or lithotripsy for stones. Now, the diagnosis for acute kidney injury, the only thing that she said about it in the PowerPoint was, if giving contrast, use massive fluid boluses. Now, the signs and symptoms of an acute kidney injury are creatinine over 1.3, bun over 20, metabolic acidosis, and urine output under 30 milliliters an hour. So what we're trying to do is find what's different with each thing, and this one's a little different. They have metabolic acidosis with acute kidney injury. Now, in the Saunders book, it says we need to monitor for hypertension, tachycardia, tachypnea, irregular heart rate.
Input and output hourly.
Yeah, hourly intake and output, daily weights, In a urinalysis, we're going to look for protein levels, signs and symptoms of infection, and here's the tricky part with acute kidney injury. The normal signs and symptoms of infection are not what you go off of, because increased temperature and increased WBCs are not going to show up in an infection for an acute kidney injury. So we need to be looking for redness, swelling, that kind of stuff. And we also need to auscultate the lung sounds because we have a risk for lung sounds related to fluid volume overload, so crackles, dyspnea, hypoxemia, stuff like that. We got 4 phases of acute kidney injury. The first phase is the onset of injury, or the initiation. Saunders, Simple Nursing, and Solomon, they all start with an S, all didn't really say anything about the first phase. But now the second phase was heavily covered in all 3 resources. So in the oliguric phase, what we're going to do is we're going to administer diuretics as prescribed. With the oliguric phase, we're going to see under 400 milliliters of urine in 24 hours. We're going to see a decreased urine-specific gravity. We're going to see a sudden decrease of urinary output, anorexia, nausea and vomiting, increased BUN over 20, hyperkalemia, which is potassium, over 5, serum sodium below 145. What are we worried about with this low serum sodium, Kayla?
We're worried about swelling of the brain and seizures.
Seizures.
But
what do you say?
it's 135.
What do you mean it's 135?
Below 135.
Below 135?
Yeah.
Thank you, Kate. That's why I brought you here.
I was trying to say it quietly.
No, just say it. It's funnier when I have narration in the background because they can hear you very well, and I'm having to speak up.
No, damn.
Hypocalcemia, and that is a calcium below 8. Now, fluid volume overload, we can see hypertension, edema, dysrhythmias, and heart failure. With metabolic acidosis, we'll see those Kussmaul's respirations. With uremia, that's going to be urine in the blood. We're going to see this with nausea and vomiting. That's how we're going to know it's uremia. And pericarditis, we know it's pericarditis if we see friction rub, chest pain with inspiration, or a low-grade fever. Now, the third phase of acute kidney injury is the diuretic phase. And in this phase, we're going to administer IV fluids as prescribed. Now, that's the tricky part. In the second stage, we're administering diuretics. But the third stage, we're giving IV fluids. Why? Because we're having an increase of urine output in the diuresis stage of acute kidney injury. We're going to see dehydration, hypovolemia, hypotension, and tachycardia. Now, the fourth stage is the recovery phase. It may take a year for them to recover. Urinary output returns to normal, increased level of consciousness, increased strength, increased glomerular filtration rate. And that's everything about acute kidney injury that could possibly be on the test as far as I know. The next thing we're going to cover, oh wait, we didn't go over treatment for acute kidney injury. Hold up.
Wait.
Treatment for acute kidney injury. According to Simple Nursing, we give them fluid boluses and diuretics such as furosemide. According to Saunders, we're going to give them dopamine, Lasix, and Bumex. Mannitol, ACE inhibitors, PPI, H2 blockers, and the PowerPoint she said antacids for the low calcium. So the antacids have calcium in it, it's going to increase your calcium.
Nice.
Now we also give them Kayla, Exhalate, if the potassium is over 5. So if that potassium's high, you bring Kayla in. She'll smack the crap out of it. She'll smack that banana at your hand, and your potassium will be 3.5 to 5. Next, we give them sodium bicarbonate. That's to treat that metabolic acidosis. We're going to be looking at their intake and output. Decreased fluid intake after volume and renal perfusion is restored. So for that intake and output, and this was in Saunders, after their renal and volume perfusion is good to go, then we got to decrease that fluid intake. I almost said decrease urine intake.
Ew.
Just as good.
That's nasty.
What did you say?
I said, that's nasty.
Hemodynamic monitoring, we're going to be looking at that CVP. We're going to increase carbs in acute kidney injury. We're going to decrease sodium and potassium in acute kidney injury. We're going to decrease proteins in acute kidney injury. And we're probably going to do dialysis at some point. But let's see, what kind of diet? Would you see canned foods, for this patient with acute kidney injury? No. What about bananas or potatoes? Nope. Let's see. What about steaks?
Yeah. No, I'm just kidding. I don't know.
No, you decrease protein.
Oh, decrease protein.
Decrease sodium and potassium.
No steaks, guys.
But now, what about jelly donuts?
Yeah.
Jelly donuts are good because
This
we
is the one
increase them
time.
carbs. So if you have an acute kidney injury, that's one good thing that comes from it. You can have a donut.
Wow.
Now we're going into the next thing, which is chronic kidney disease, which is slightly worse. So we're doing it in red. So
Red.
chronic kidney disease, this is a gradual loss of kidney function over time. And we're going to see a GFR over 90 milliliters a minute. Now, 90 milliliters a minute is normal. So, I screwed that up. CKD, we got a gradual loss of kidney function, and GFR is normally over 90 milliliters a minute, but GFR will decrease as chronic kidney disease progresses. Stage 5, which is the worst, is going to be 15 or lower, which is the main thing she said to know in the PowerPoint.
Stage 5 is 15 or lower GFR?
Yes. Normal is 90 or higher. Am I good?
Yeah.
Okay, cool. Dialysis is the primary treatment for chronic kidney disease. Probably a kidney transplant also, or one of those things. Now, causes for chronic kidney disease can be older age, long-term chronic damage from uncontrolled diabetes, and PowerPoint she said that was 50% of the cases of chronic kidney diseases from uncontrolled diabetes, and we could also get it from hypertension. We can also get it from unchecked autoimmune disorders. So if you got lupus, you're at risk for chronic kidney disease. Infection, acute renal failure, polycystic kidney disease is something the simple nursing said, I don't know. But diagnostic is going to be the same for all creatine things. Not all creatine, all kidney things. That's how good I got it. I just automatically switch kidney and creatine. That's how you need to have it.
That's how you do it.
So what is normal creatinine? It's definitely lower than 1.3 because with this patient, it's going to be over 1.3. So we're going to do the creatinine clearance test. With that, we're going to do a 24-hour urine. We're going to put that pee on ice. We're going to waste the first urine specimen, and we're also going to get a blood specimen with this. Now, the signs and symptoms of chronic kidney disease. We got oliguria, which means less than 30 milliliters an hour or less than 400 milliliters a day. Metabolic acidosis, where that pH is below 7.35. Uremia, or uremic frost, which is pruritus. That's what simple nursing was saying. We're going to see a sodium over 135. Yeah. And we're going to have a phosphorus over 4.5. A potassium over 5. So just look at all these labs of chronic kidney disease. They're all elevated. Increased sodium, increased phosphorus, increased potassium. And with that potassium, we got to worry about hyperkalemia. And with that, we're going to see a YQRS, peak T waves, and an ST elevation. We can also see bradycardia, weakness, fatigue, and lethargy. Now we're going into what Saunders said. They're going to have uremia, which is urine in the blood, nausea, apnea, weakness, fatigue, lethargy, confusion, fluid and electrolyte imbalances, and something lower than 10.
That's decreased level of consciousness.
Oh, 10C. Yeah, decreased level of
It'd be your own
consciousness.
handwriting.
What did you say?
It'd be your own handwriting that betrays you.
I'm trying to get through this quick, so I'm reading it. I'm speaking it as I read it. We're going to monitor for hypotensive crisis. Now, this is a priority thing, this hypotensive crisis. It requires an immediate assessment. We're going to have increased blood pressure, and we have a risk for heart damage or a stroke. They're going to have headache, nausea, vomiting, and decreased LOC. So what do you think we're going to do for that, Kayla?
Give them vasopressins.
Vasopressors?
No, fluid.
If they're in hypotensive crisis, what is our priority nursing action?
Cameraman don't know.
Camera woman.
The camera woman don't know.
Let's see. I would say contact the
Hypotensive
healthcare
crisis.
provider.
They have an increase. So you want to increase the blood pressure?
No, they're going to have an extreme or hypotensive crisis.
Yeah, you're gonna give them
I think
fluids.
it's a
You're gonna give
I
them.
think it's a hypertensive crisis. I meant to write there. Same as the other one. Increased blood pressure, risk for strokes, heart disease, headache, nausea, vomiting, decreased
It is
LFC.
hypertensive.
That is increased intracranial damage. So that is a bad on me. It's hyper.
And what do you do with that? You're gonna give them like beta blockers, calcium channel blockers,
Diuretics.
diuretics.
Call the HCP. I don't know. That seems like a good thing to do for that. Let's go into the treatment for chronic kidney disease. I'm going to go over that. Note to self. Later I'm going over that.
I need to too.
Treatment, dialysis or hemodialysis. We are going to have a decreased potassium diet. Now, we are going, if they have arrhythmias, right? If they have arrhythmias and that potassium is over 5, we are going to give them IV calcium gluconate or Kayla Exolate. Smack that banana out the kitchen can. You know what I'm saying? There it is right there, Kayla Exolate. We can also give them IV 50% dextrose and regular insulin. That will lower potassium. We need to do daily weights. Same time every day. 1 kilogram equals 1 liter of fluid. So we're going to need to avoid NSAIDs, antacids, mycin-ending antibiotics like gentamicin. And we are also going to avoid CT contrast dye. Main treatment for chronic kidney disease is this kidney transplant. Now the diet we need to have for chronic kidney disease, we are going to decrease fluid and decrease sodium. We're going to decrease phosphorus, decrease protein, and potassium. I said that backwards. And that's what Simple Nursing said. Here's what the book said: decrease protein, decrease potassium, decrease phosphorus. Oral care for mouth sores, and skin care for pruritus. And that's all you need to know, as far as I know, for chronic kidney disease. Let's go into the next thing. Dialysis, which is going to be a majority of the exam, from what I understand, at least 8 questions on dialysis. So with dialysis, we are going to be giving dialysis for people that are in renal failure. And dialysis is going to clean the blood of all the bad stuff that's clogging up the kidneys. It's not for the hemodynamically unstable patients. So if they're hemodynamically unstable, dialysis is contraindicated. So let's start with the first type of dialysis, which is hemodialysis. And with hemodialysis, you're going to have a shunt in the arm. And it's going to need to be done 3 to 4 times a week. Potassium is the priority lab here. If their potassium is high, we can give them calcium gluconate, insulin, and
Kayla
Exolate. Exactly. Now we're going to have a fistula with both of the types of dialysis. Well, not both. We're going to have a fistula with hemodialysis, and we're going to get them to squeeze a ball. Why? I don't really know. It's probably to help the arm muscle, or probably prevents edema that is normal. So if they have edema, that usually goes away in a few days. So don't call the primary health care provider if a patient with a fistula has edema. But here's what you do want to call the health care provider for. If this patient that's going to get dialysis has a fistula, if they have pallor, paresthesias, decreased pulses, decreased capillary refill, or pain distal to the shunt, we got to report that bad boy to the primary health care provider, because that is not good. That is showing a lack of circulation. Now we need to monitor for infection, bleeding, and we need to fill a thrill once a day. Fill a thrill, palpate a bruit, I think. We need to avoid all these following things for fistulas, patients with fistulas. If you go to get a blood pressure, you do not want to do it on the affected arm. If you see them sleeping, make sure that they are on the unaffected side. So if they have an AV fistula, probably in their left arm. You don't want to put it in the right arm if it's in the left arm. If they sleeping on the left side, you've got to flip them over.
Okay.
You don't take blood pressure on this left arm.
Yes, sir.
No lifting over 5 pounds. No restrictive clothing. We need to pull the needle out. When we pull that needle out, we need to hold a lot of pressure on there because we have an increased risk for bleeding. No venipuncture on the affected side, and we need to have this fistula in 6 weeks before we use it. And an inclusive dressing is used over the catheter insertion site. The biggest thing with all of this is infection. That's what I missed on the last test. I picked bleeding over infection, but I'm not salty at all. So let's talk about
Your face says it all.
before hemodialysis. We are going to assess the fluid status. We're going to look for edema. We're going to check the condition of these access devices, also known as the fistulas. We're going to look at the temperature of the patient and the skin condition of the patient. We're going to feel a thrill and hear a bruit, not palpate a bruit, hear a bruit. And if they're absent, what do we do? What do we do, Kayla?
Report to healthcare provider.
Yes, good job, Kayla. Now, what do we hold before hemodialysis? That was on the last test also. We need to hold these antihypertensives, these ACEs and ARBs, the PRILs and SARTANs, the beta blockers, the LULs. You know what I'm saying? So ACEs and ARBs, ACEs are PRILs, ARBs are SARTANs, beta blockers, and then LOL. Calcium channel blockers, they end in dipine, amyl, and zim. That sounds like a boy band.
It really does.
Like One Direction. CCB featuring dipine, amyl, and zim. Diuretics. We need to hold these before hemodialysis. The ones that end in ide, like furosemide, and any of those thiazide diuretics. Now, we also, with dialysis, something with nitroglycerin.
I think you hold nitroglycerin because
hold
you're going to
nitroglycerin.
drop the blood pressure.
Dilators, vasodilators, nitroglycerin. Okay, so no blood pressure meds 4 to 6 hours prior to getting hemodialysis. This is all the stuff from Simple Nursing and Saunders. This is from the PowerPoints. Do not administer meds until after dialysis is over, which is just a safe thing to do because all of these drugs are contraindicated. Let's go into the during hemodialysis. Now what we got here? IV heparin is added during dialysis to prevent clots. So that's fine. If the student nurses, can student nurses do dialysis? I don't think so. Okay, so if a newly trained dialysis nurse is putting heparin in the dialysate, that is not a need for further instruction. That is totally fine. Now, calcium carbonate is given for numbness and tingling in the hands. Is that the same as calcium gluconate? Probably not.
I don't think so.
Now we have a risk for disequilibrium syndrome, and this is before and after. I just wrote all through what I was going to say. The brain cells swell with disequilibrium syndrome, and we're going to have an increase in ICP. So the signs and symptoms of this, they're going to be restless and disoriented. We're going to have vomiting and headache. If this happens, we stop and slow the infusion, then we notify the HCP. We got to worry about bleeding and hypovolemia during hemodialysis. Now, be alert, according to PowerPoint, be alert to changes in condition. So, I'm going to talk about changes in conditions. We need to perform vitals every 30 to 60 minutes. If we have an increased LOC during dialysis. Should increased LOC during dialysis? Oh, okay, so the level of consciousness should increase during dialysis. I reported that wrong. Blood pressure is done every 30 to 60 minutes to monitor for hypotension. So the vitals, blood pressure, if they have cramps, we give them mannitol. Yeah, so here's some other things that Saunders said about dialysis that I could not think of. We're going to go into post first. Post-hemodialysis, we need to monitor for signs and symptoms of bleeding and hypovolemia. So, let's see. Bleeding and hypovolemia. We got hypotension, tachycardia, all those signs and symptoms. I think cool, clammy skin, pallor, all those things. Dialysis, after we have that disequilibrium syndrome, headache, nausea and vomiting, decreased level of consciousness, hypertension. Don't forget, if that happens, we need to slow the infusion, then we notify the healthcare provider. The first thing you do is slow the infusion. Now, we also need to, after hemodialysis, we need to monitor the patient's weight, and we need to weigh the bed. So the beds are weighted, and we need to make sure that it's a consistent weight. So if there's one blanket and a pillow, we make sure that the same blanket, the same pillow is on the bed before and after. We need a very accurate weight on this patient. So now Saunders, just crap it said about hemodialysis. Before, during, after hemodialysis, we need to look at these vitals and temperature. If it's excessive, it could indicate sepsis. And that means we need to get blood cultures. So increased temp before, during, or after, like really high temp, like 101, 102, we need to get these blood cultures. Lab values, we need to check these before, during, and after dialysis, the BUN and CBC. We also need to assess the patency of the blood access device, also known as a fistula, before, during, and after hemodialysis. Just before, here's the things we do before. We need to monitor for fluid volume overload before. And then after, we need to monitor for fluid volume deficit after. Before and after, we need to weigh the patients. Signs and symptoms of complications with hemodialysis. Signs and symptoms of complications. If we just have complications, we slow the dialysis or stop it, and then we notify the HCP. Make sure you stay with the patients in signs and symptoms of complications. Yeah. Air embolism. You stop the hemodialysis. This isn't slow. Air embolism. You stop it. You turn the patient to the left side with with their head down, also known as Trendelenburg. Now this is for an air embolism in hemodialysis. We got to notify the HCP, the primary healthcare provider, and the rapid response team. We're going to administer O2, assess vitals and pulse ox, and we're going to document all this after it's over. And you sure as crap better not leave the patient in any of this. Next, we're going to go over peritoneal dialysis. Where did I put my other highlighters or whatever you call these things? Peritoneal dialysis. Basically, it's like hemodialysis, but there is no shunt. There's less information all over the board on this. So I'm going off of what little is in the book, what little is in the PowerPoint, and what little simple nursing said. So, no shunt. It's contraindicated in patients that have peritonitis, any GI problems, or recent abdominal surgery. So if they had any of those things, peritoneal dialysis is not for them. Now, before peritoneal dialysis, we need to take the patient's weight, warm the patient's solution, monitor for vital signs. The bladder must be empty according to the PowerPoint, and we need to avoid if possible beforehand. So you get the idea. During, we need to monitor the vital signs. If they have respiratory distress, we can see it with pain and discomfort. We need to monitor for the signs and symptoms of pulmonary edema, hypo or hypertension, malaise and nausea and vomiting. Outflow should be a continuous stream, and if we see frank blood, cloudiness in the outflow, what do we need to do?
Notify the healthcare provider.
Notify the healthcare provider. So complications for peritoneal dialysis. The biggest one is infection. So we need to make sure we use sterile technique. Now, peritonitis is another complication with peritoneal dialysis. And with this, we're going to see fever, increased heart rate, cloudy drainage, and we need to culture.
You're going to see a board-like abdomen too.
Oh, and a board-like, that's huge. How did I miss that?
I think.
Well, it's certainly not good. You need to do something if you see a patient with peritoneal dialysis with a board-like abdomen.
I believe that's what you do. I believe that's a sign.
I'd be over here like patient with a board-like abdomen. That means we got to saute some onions on this bad boy. Culture. We're going to give them antibiotics, which may be added to this peritoneal dialysis dialysate. If we have decreased outflow, we need to make sure they have a high-fiber diet. We may give them stool softeners. And if we think it's a cath migration, we got to do a X-ray. Probably not a chest X-ray, but chest X-ray. Respiratory distress, increased respirations, dyspneas, crackles. First action in respiratory distress with peritoneal dialysis is elevate the head of the bed. Now we're going into insufficient outflow. This is what the book said. If we have insufficient outflow with peritoneal dialysis, we need to assess the patient's abdomen. We need to assess this abdomen for distension and constipation. We also need to look at the access device. The catheter may have kinks or it may be obstructed. Interventions. First, we're going to reposition the patient to the side-lying position. So if we have insufficient outflow, we're not going to immediately call the healthcare provider. We are going to turn the patient to a side-lying position And I guess if it doesn't get better, then we'll call the healthcare provider. Post-dialysis, we increase that protein. Protein. Kidney transplant, not much on this either. Kidney transplant,
She said we didn't have to know kidney transplant.
She did whenever I taught. Where did she say we didn't have to know it?
When we took our test, she said don't do transplants because they're uncommon to get on the list. But she said it. She said it for the final.
For the final, so I just did this.
Never mind.
It's probably just gonna be one question at most. So I did. It's all over the place because there wasn't much on it, and I was trying to get done. But kidney transplant. Let's go with the green one. According to simple nursing, we give them immunosuppressants before. The one that they mentioned was cyclosporine. We're going to monitor that urine output. 30 milliliters an hour or less means the kidneys are in distress. We're going to watch for signs and symptoms of infection, like temperature or low-grade fever. Signs and symptoms of organ rejection is hypotension or pain at the site. We're going to give them a diet that's low in fat and high in sodium. Treatment for end-stage renal disease is kidney transplant. And the benefits of this, and now we just switched to the PowerPoints because it jumped, it's going to be less expensive than dialysis, and we're going to have an improved quality of life. Now, immunosuppressants, according to the PowerPoint notes, Urine and Cellucept are the ones that she mentioned. So remember, cyclosporine, Urine, Cellucept. And this can be given in combination with prednisone, so we need to monitor for osteoporosis and Cushing's syndrome. Post-operation of a kidney transplant, we need to have a Foley at that bedside ready to go. Intake and output every 30 to 60 minutes. We need to avoid prolonged sitting, avoid contact sports, obviously. Monitor for signs and symptoms of infection, and avoid sick people. Just do that anyways. That's always a good thing to do. Now, another thing is if it's a cadaver kidney transplant, then it's going to take longer for the urine output to return than it will a live one, but I didn't think that was important, so I didn't put it on there, but for some reason I'm telling you now. Signs and symptoms of a kidney transplant rejection. Temperature over 100 degrees Fahrenheit. Pain and tenderness over the grafted area. 2 to 3 pound weight gain within 24 hours. Edema, hypertension, malaise. Increased BUN over 20, increased creatinine, which is over 1.3. Oh, you got it. Increased WBCs. What's that going to be?
Over 10? 15?
Over 10,000.
10,000?
Yeah, it'd be like, I think it's 1,100 really. Rejection is indicated via ultrasound or biopsy. So I think the one question we're going to have over a kidney transplant is going to go, a patient suspected of kidney transplant rejection has just come into the ER. Which of the following diagnostic tools would the nurse expect to be given?
Which one? What's the answer?
You gonna say it?
Ultrasound or biopsy?
Are we gonna do a CT scan?
No.
Are we going to do a, what would they get us with? Are we gonna do a CBC?
No.
Are we going to do a urinalysis?
No.
No, we're going to do a urinalysis and a biopsy.
An ultrasound? You said urinalysis.
Urinalysis? No, an ultrasound and biopsy. Yeah. So thank you so much, Kayla, for being camping man today. I appreciate it. This is 11 questions on the test, and that's all.
11 questions for all
I think
that.
it's the crap I really needed the most, to be honest with you. I don't remember any of this. Well, I mean, I do now.
I remember. I'm turning it off.
So now we're going to go over liver, which is 6 questions. Specifically, we're talking about cirrhosis. So let's get into it. Cirrhosis, we have destruction of the liver, and we got scar tissue with this. So right out the gate, we get a different colored expo marker. For pathophysiology, we're not going to cover it too much. This is my marker. You got Lane cirrhosis, which is alcohol. You're drinking too much alcohol. You got chronic hepatitis that can cause cirrhosis, and you also have cystic fibrosis, which can cause cirrhosis. So, the liver, what does it do? It detoxes ammonia. It does drug metabolism. And it stores bile, clotting factors, and albumin. So the liver basically makes albumin, bile, and clotting factors. So if we have cirrhosis, which is destruction of the liver, and the liver can't make what it needs to make, we're going to see decreased albumin, decreased bile, and decreased clotting factors. So with cirrhosis, of course, we have decreased albumin. Now if we have decreased albumin, we're also going to have decreased calcium, and that's going to mean osteoporosis, Trossards, and Chavez. So Trossards and Chavez are basically shaking. We got tremors, Cirrhosis in the face, and Chavez is in the arm. Yeah, when they do the blood pressure, twitching in the arm. Hysteresis. And to measure hysteresis, we need to make sure we have the arm extended. We're going to have an increased cholesterol. We're going to have an increased bilirubin, which is going to lead to jaundice. They're going to be yellow with cirrhosis. We're going to have decreased clotting factors and a risk for bleeding with this. So we're going to have an increased PT and PTT. You know what that means? If they're bleeding, we got to hold pressure. The next thing we're going to see is anemia, leukopenia, and thrombocytopenia. So anemia, that's that decreased albumin, another train. Decreased albumin. And with leukopenia, that's decreased WBCs, and thrombocytopenia, which is under 50 on the platelets. The next thing we're going to talk about is the same thing. We're going to have increased ammonia, right? And that's going to lead to hepatic encephalopathy. We're going to see hysteresis, which is the twitching we were talking about earlier. And the test for that, you have the arm extended, and we also have a decreased level of consciousness. Now, these patients with cirrhosis are at risk for drug toxicity. So basically, we need to be careful in giving them drugs because their liver can't, synthesize it. We definitely need to avoid acetaminophen. And the antidote for acetaminophen, which is acetaminophen overdose, can cause cirrhosis. The antidote to that is acetocycline, also called mucomox. Okay, now for the signs and symptoms of cirrhosis, the ones mentioned in Saunders and Simple Nursing. So signs and symptoms, we're going to have an increased blood pressure. This is going to lead to portal hypertension, which will lead to splenomegaly. Now, the splenomegaly, we also have esophageal varices from this increased blood pressure, this portal hypertension. Now, ascites, that's fluid filled in the abdomen. And to get rid of that, we do a paracentesis. Esophageal varices, that's in the throat. That portal hypertension, it's going to lead to jugular vein extension. And if it ruptures, airway. So basically, we need to make sure we don't do vagal maneuvers. No straining when you're pooping, so I can see administering a stool softener. We do no NG tube, and because we have a risk for airway obstruction here, like they can't breathe. And so if a nurse that's unexperienced puts in an NG tube, or they somehow rupture it and they're bleeding, what do we need to do? We need to turn them to the side. Now, hepatic encephalopathy, as we were talking about earlier, that's that twitching, that hysteresis. We're going to have a decreased LOC, increased ammonia, and we also want to decrease the protein in that diet. Now we're going to have decreased clotting factors, decreased albumin, decreased calcium, and decreased platelets. So think about it, like we said earlier, it makes albumin, bile, and clotting factors. So decreased clotting, decreased albumin, which also means decreased calcium. We're going to have twitching in the extremities called hysteresis. We're going to have a decreased level of consciousness and an increase in that ammonia because the liver can't convert the albumin into ammonia. We're going to have increased ALT and increased AST, increased ammonia and increased bilirubin. Now we're going to see pruritus with these patients. What is that? It's itching. So we need to make sure we do a cool, moist cloth in the affected area. No hot showers, no hot baths. Moisturizer to unbroken skin and long sleeve clothes, cotton gloves. Trim those fingernails. Also mentioned in the PowerPoint notes, we got this hepatorenal syndrome. We're going to have decreased urine output, and we also have fever hepaticus, which was in the book, which is fruity breath / odor. So now, let's go into the next thing. We're talking about a large fatty liver in the first stage. So we need to get them to stop drinking. The second stage of alcoholic cirrhosis, we have alcoholic hepatitis. And with that, we got scar tissue formation. In the third stage, which is the end stage of cirrhosis, we're going to have little function of the liver remaining. Probably going to need a liver transplant. So diagnostics for cirrhosis, we're going to do a liver biopsy. Now that comes with its own thing. We need to have them, after this, we need to have them lie on the right side. And if they start bleeding, we put pressure on them. Think about it. They have increased PTT, increased PT, decreased clotting factors. So they are at a high risk for bleeding and going into hypovolemic shock. Same with that esophageal varices. Interventions, now for the societies or the paracentesis, we need to empty the bladder beforehand. You got me? So with ascites, we do the paracentesis, and we make sure we have an empty bladder beforehand. We need to monitor the vitals, specifically the blood pressure. We need to measure the abdominal circumference and weight. Now that is with the paracentesis, that we empty the bladder, check the vitals, and measure the abdominal circumference, and we measure their weight because we're dealing with fluid. So we're going to increase the head of the bed to high Fowler's position. Now we're going to administer albumin IV, and it's going to increase the blood pressure, and they're going to have a bounding pulse, but that's okay because then we're going to give them furosemide. So how do we know if this albumin is effective? Normal vital signs, not any of this crap with paracentesis. If it's albumin and we want to check the effectiveness, we need to make sure they have normal vital signs. Now we're going to increase the protein in the diet. We're going to give them vitamin A, B, C, folic acid, and thiamine. That came from the book and I didn't know why, but I checked the PowerPoint notes and it said it was for, oh my gosh, let's see. It was for something. Now, we're also going to give them glycolose. I mentioned that in the orange book. And also for checking that atelectasis or whatever this axaderixis, we need to extend the arms. Now, manifestations of cirrhosis, according to my PowerPoint notes, we have GI disturbances, anorexia, dyspepsia, flatulence, nausea, vomiting, change in bowel habits, and gynecomastia. Okay, last things we're going to cover here, we got more stuff from the textbook. This is treatment actually from class notes. We need to monitor for hypoglycemia with these patients. Now, if they have hypoglycemia, we give them what? Glucose or something with sugar in it. We need to put them on bed rest, and we need to do sodium and fluid restriction. Now, we're going to give them diuretics, and we're going to do a paracentesis, and we're going to give albumin. That's the mode treatments I mentioned. Sodium, we want to keep it under 2 grams. Fluid between 100 and 1,000 cc's. Protein, 60 to 80 grams a day. We're going to increase calories, so that's good. They can eat donuts. What else we got? Meds, we give them PPIs, and that's going to decrease the gastric secretion. That was on my last test. We're going to give them antacids, and I got the question right. We're going to give them H2 receptor blockers, mucosal barrier enhancers like Carafate. We're also going to give them antibiotics. Now, if we have variceal bleeding, what are we talking about? We're talking about something here. Esophageal varices? Oh yeah, variceal, esophageal varices. So I can just turn this fan off and make it quieter, can I? Right now that we're at the end of this. For the variceal bleeding, we're going to give them somatostatin, octreotide, and a vasopressin drip. That's all for liver, which is 6 questions. Next, I'm going to go into kidney, because this is going to be the video crap that I definitely need to know. Okay, so really quickly, we're going to go over hemodialysis. There's only 2 questions on it, and I went through the hemodynamics section, and this is just from my PowerPoint notes. Level, to get the level, is the phlebistostatic axis, 4th intercostal space, mid-axillary line, level of the right atrium. Now, arterial pressure monitoring, that's done the radial artery, Allen's test prior, and if it's under 5 seconds, we Gucci. We got to worry about thrombosis, air embolism, hemorrhage. We need to check circulation of the extremities. Now, RAP, that's normally 2 to 6. Under 2 is hypovolemia. Over 6 is fluid volume overload or right-sided heart failure. PA cath, we need to make sure they're in the Trendelenburg position, and towel under the shoulder blades. Post-insertion, we need to make sure that zero reference is good. We need to do a chest x-ray to make sure it's good. It's going to be 1.5 milliliters of air going into this PA cath. PA systolic should be 15 to 30, and diastolic should be 4 to 12.